The broadcast is now starting. All attendees are in listen-only mode.
Good morning and welcome to this new webinar organized by the Maternal Health Supplies Caucus of the RHSC, Reproductive Health Supplies Coalition. My name is Milka Dinev. I'm the technical backstop for the Maternal Health Supplies Caucus, and I will be the moderator of this webinar. Today we are presenting very interesting work that the SIAPS project of MSH and USAID has been conducting in 4 countries. And this interesting work is based on the financial flows for maternal, newborn, and child health medicines. Mahin Malik and Jane Briggs from MSH SIAPS will be making the presentation, and they'll introduce themselves. All the participants are in listen-only mode. You're all muted in order to prevent background noise from your offices. All the microphones have been turned off. We will leave questions for the end of the presentations, but please, while the presentation is being broadcasted, you may write your questions in the section to the right of your screen where it says questions. You can start writing them as soon as you have a question. At the end of the presentations, we will read all the questions. We have enough time to read all the questions, and our presenters will kindly respond to them. This webinar is being taped, so we will have the video and audio of the webinar, which will be loaded in our website. I will send you in a couple days an email with the links to the YouTube channel where the webinar will be recorded. Do not hesitate to contact me at mdnev@rhsupplies.org if you have any other questions or if you would like more information on the webinar. Or you can also contact me through the chat window, also to the right of your screen. I repeat, all of your microphones have been muted. Make sure you have a good set of headphones, and in order to save bandwidth and you have no internet problems, make sure you close any other programs that you're not using, any other software. So if you have Skype or WhatsApp or something else opened in your computer, make sure you're closing all of that. Close your email. That will give you a better listening experience. So with no further delay, I will pass now the microphone to Jane Briggs, who will introduce herself, and Mahin, and we'll start the presentation. Go ahead, Jane.
Thank you very much, Milka. Thank you for giving us the housekeeping and instructions for the webinar. Mahin Malik and myself, Jane Briggs, we will be presenting this webinar together. We both work on the SIAPS program implemented by MSH, funded by USAID. SIAPS stands for Systems for Improved Access to Pharmaceuticals and Services. Mahin, my colleague, is a technical strategy lead at MSH and has been working, among other areas, in the MCH portfolio of the SIAPS program. And myself, as a principal technical advisor, I've also been working on the MCH portfolio of the SIAPS program. And so today we're going to present a summary of the key findings from studies that we conducted in 4 countries, Bangladesh, Kenya, Nepal, and Uganda, to map the financial flows for MNCH medicines. Now, I have an accent, Milka told me, and Maheen does also, so we will try to speak slowly and carefully so that everybody can follow. Do let us know if there's any problems following what we're saying so that we can slow down or clarify. I don't think we can change our accents. I also have come down with a cold last night, so if I start to sneeze, I will try and hit mute before I sneeze, but if I don't, apologies in advance. So let me go a little bit through the background first. If you could move to the next slide, please. So the background to this work is fairly self-explanatory in many ways. We know that the continuous availability of MNCH commodities is very important for maternal, newborn, and child health outcomes, but also it's critical for countries to achieve their SDGs. In many countries, MNCH commodities are procured using government funds as opposed to other program commodities such as family planning, HIV, TB, malaria, where donor funds are more often used. So government funds are usually used to procure these commodities, often as essential medicines. But in general, we found that there's a lack of evidence as to how decisions are made for financing these commodities within that group of essential medicines and how those decisions are actually executed. And so the idea for this work came at a time when the UN Commission on Life-Saving Commodities for Women and Children was coming to an end, and the Global Financing Facility was just starting up. This time also there was a talk of a commodity credit facility for MNCH commodities. So that was kind of the backdrop around the time we started thinking about this. And we know that through the UN Commission, a lot of attention had been focused on looking at the availability of commodities and how to assure the availability of commodities. And we found that one of the main barriers to availability was the financing of commodities. But we thought it would be useful to explore, was that just an issue of having funding available, or were there problems in the flow of funds through the system? And so, thinking with the backdrop of the commodity credit facility, if a credit facility was made available, would that actually solve the problem? And so that was the backdrop to this work. And moving on to the next slide, to go through sort of the purpose of the studies, we had developed the idea to conduct this mapping of the flows of finances through systems to inform the development of strategies and interventions that can address any bottlenecks that were found in the financial flows and thereby improve the availability of MNCH commodities. Now, this mapping was primarily conducted in the public sector. So we mapped the financial flows of MNCH commodities in the public sector. And we built on work that had been conducted by JSI, mapping sources of finances for procurement and mapping distribution. We also built on work by Results for Development, also work that SIAPS has been looking at on pharmaceutical expenditures. And we wanted to really look at how finances flowed through the system within the Ministry of Finance and Ministry of Health to the point where they're actually used for procurement. And so we looked at the process of budgeting and how the amounts are determined within a resource envelope. We looked at the steps following the budget development, which include disbursements, expense reporting, and other steps to lead towards the funds being available for procurement. And the idea around this mapping was to identify the bottlenecks that could be addressed to increase the efficiency and the way that available resources are used, and those available resources primarily being domestic resources. So moving to look at the methodology, we conducted key stakeholder interviews in the 4 countries and also a review of relevant documents. We developed tools to guide these interviews in country, and Maheen has been very much involved from that early stage in this work. We did take a look at the work of others in this field, for example, JSI, R4D, and from looking at that work, we then went on to develop tools to apply in countries to look at these different components. The components that we looked at were budget development, the budget approval, the disbursement of funds, the timelines for the budgeting cycle, the financial flow for MNCH Commodities, expenditure tracking, what gaps there were in funding for MNCH Commodities, and commodity security. In each of the countries, we hired consultants, and the selection of our consultants was carefully done to ensure that we had somebody that was very well connected within the system and could easily approach different stakeholders about some of these issues, which are actually quite sensitive. As Maheen will show later on, we talked to people in the Ministry of Health, but also people in the Ministry of Finance. And often the initial reaction to the discussion with the consultant was, no, there's no problem with the flow of finances through the system, no problem with procurement or available funding for procurement. But only after there was some delving a little bit deeper did some of the bottlenecks start to emerge. And so because of the choice of the consultant in each of the countries, we were able to get into some of those bottlenecks. We used Tracer Commodities, Tracer MNCH Commodities, to have a look at whether, for example, there were specific budget lines for those commodities. But many of the findings are not specific to MNCH Commodities, but health financing in general, and particularly the fact that MNCH Commodities are procured through budget that's assigned for essential medicines. So now that I've given the overview, I'm going to hand over to Maheen to talk us through how we did the work and some of the key bottlenecks that we discovered. And then I'll come back at the end to pull it together. Over to you, Maheen.
Thank you, Jane. So as Jane has explained, we looked at 4 different countries. However, what we found out that a country's budgeting process and financial flows in general for all medicines, which includes MNCH medicines, varied largely on whether the budgeting and procurement occurs at the national, which kind of represents a centralized system, or at subnational level, which represents a decentralized system. And there are countries which have a mix of both systems. So local governments or health facilities are also allowed to procure health commodities, and this happens both in a centralized and a decentralized system. The health system structures in the assessment countries varied. For example, in Uganda, it has a centralized health system, whereas Kenya has a completely decentralized system since the devolution happened and the county governments had the autonomy to make decisions. And in this situation, Ministry of Health only plays a leadership role and manage vertical programs at the national level. There were countries, for example, Bangladesh and Nepal, which have components of both a centralized and a decentralized system. And so the commodity budgeting and procurement happens both at the national and the subnational level. So as for the first component that we tracked, which was on the budget development, its approval and disbursement process, we first looked into the timelines. The average timeline from initiating the annual budget development process to final approvals and disbursement of funds is almost about 9 months, with slight variations where countries have processes which may require them to have a wider time frame. For example, in Bangladesh, where a 5-year plan is made, and so it requires almost a year for them to finish the whole planning process. There are key stakeholders who are involved in the entire health budgeting process within the public sector, and these include Ministry of Finance, Development Economic Planning Commissions, Ministry of Health, Cabinet, Parliaments, and each one of these have a specific role to play when this budgeting is happening. Budgets mainly depend on what activities a country plan, and so in discussions between the stakeholders, they agree on activities, which also involved what commodities will be required based on the activities that they finalize. Kenya develops its health budget at the county level with no inputs from Ministry of Health, which only manages the national level health services. in which case the primary role of the national level is just to determine county level ceiling budgets. Otherwise, most of these are managed at the county level. Stakeholders have different roles. For example, the stakeholders that we interviewed within Ministry of Health were those responsible for program planning as well as finance planning. We interviewed people from Ministry of Health, which were dealing specifically for the budgets with Ministry of Health and who are responsible for coordination between Ministry of Health and the Planning Commission, who is the body that approves any program that will be implemented by Ministry of Health in a certain country. We also spoke to donors, which included mainly those who are responsible for procuring MNCH commodities, for example, USAID, UNFPA, UNICEF, just to ensure how the process of discussion happens between Ministry of Health and these donors. Additionally, there were bodies like sector budget working groups, central medical stores, who are not directly involved in the budgeting process, but are responsible for some implementation once the budgets are approved and the procurement for medicines starts. Ministry of Finance usually is responsible, so they are the ones who start the process for budgets, and a circular is sent by them, which include guidelines, deadlines, budget ceilings, which is mainly determined on last year budgets. Once the budget ceilings have been decided, it is communicated to the Ministry of Health and local governments, who then develop their budgets. They're also responsible for reviewing the initial budgets developed by individual ministries, have discussions. They kind of mediate these discussions between Ministry of Health and the Planning Commission. Then we have Planning Commission, who sets priorities and strategies to ensure that these budgets are aligned to reflect the national priorities. Ministry of Health is the implementing agency who is responsible for coordinating with relevant departments within the Ministry of Health, agree on priorities within the departments, agree on budgets which are for the departments. They make an initial budget, consolidates, sends it to Ministry of Finance and to Planning Commission, where major discussions happen once everything is agreed upon. These budgets are either entered into an online system, for example, in Nepal, where there is a budget line information system, or paper-based budgets are submitted to Ministry of Finance, who would take it to the Parliament for approval. Once the Parliament approves, the reverse happens. Ministry of Finance receives the information on approved budget, who would then pass it on to Ministry of Health so that they could start implementation of the activities they had planned. So countries have, as I mentioned, have a centralized and a decentralized system. This graphic has been adapted from Uganda, where there's a completely centralized system and most decisions are made at the national level. In a centralized system, the national level government holds funds, pays the supplier for commodities. For example, in Uganda, the Ministry of Health budgets for these commodities, and a national medical store procures and manages health commodities. Ministry of Finance would include the budgets which is from the public sector, gives it to Bank of Uganda, who would hold the funds and pays the supplier once the national medical store submits supplier invoices. And so in this case, the funds for commodities are not passed on to Ministry of Health, neither to the national medical store, but they sit within the Bank of Uganda, who's responsible for payment. This has a benefit that these funds are not touched for any other need. And so if whatever is approved for commodity procurement sits there, can be used for commodity procurement as and when it happens on request of Ministry of Finance to the central medical store. As I mentioned, most discussions only happen at the national level. There is very limited or little input which is sought from the subnational level. Whatever is approved is signed off by the Parliament. Ministry of Finance has this earmarked for commodity procurement and passes this on to the Bank of Uganda, so that when the procurement happens and a confirmation is sent from National Medical Store and Ministry of Health to the Bank of Uganda, the payments are made. Most of the forecasting, quantification, procurement happens at the national level. And for example, in Uganda, health facilities are not allowed to procure medicines. They usually receive medicine from the national level. The central warehouse, which would receive the commodities, is responsible for distribution to the level of health facilities. Also, in case where there's a combination of a centralized and a decentralized system, for example, what we observed in Nepal and Bangladesh, the Ministry of Finance would pass on the funds to Ministry of Health at the central level. At the same time, some funds are earmarked for procurement that may happen at the subnational level, and these funds are directly passed on to the subnational level. And when need arises, they do have the funding to procure commodities at the subnational level. From the national level, it's the central medical store who procures and pays to the supplier. For the subnational level, it depends on the district who receives the fund, or even the superintendent of the hospital who may be procuring from the local market and pays directly to the supplier. Then we have a decentralized system, and this example has been adapted from Kenya. In Kenya, once the Ministry of Finance disperses funds to the counties, the county treasury combines these national level funds from government revenue and donor funds with the county revenue and make payments directly to the suppliers. Health facilities, particularly county hospitals in some counties, they do receive extra funds for emergency procurement, while some facilities generate revenue as well, which is used for procurement of commodities. Looking at the two systems, in this case, most of the discussions, they happen at the national level, and at the subnational level. The national level is only responsible for advocacy, leadership, guiding the subnational level how to make these decisions, how to help them quantify and forecast, but the procurement basically happens at the subnational level. And so we looked at the two systems, a centralized and a decentralized system. And while a decentralized system may appear to have more flexibility or greater efficiency, it was seen that both centralized and decentralized systems have their own challenges. And in a decentralized system, when the counties or the subnational level has the capability of making decisions, their capacity needs to be built to ensure that everything is in line the way it would happen if this was happening at a national level. Nepal and Bangladesh, who have a combination of a centralized and a decentralized system, we realized that was something, at least with the level of information we were able to collect, was working the best, because then the subnational level also has some amount to do the procurement. Based on our findings, we were able to identify common bottlenecks. And so the first bottleneck that we were able to list was these funds for health commodities are not enough, and since these are not allocated based on evidence. And the different reasons that we identified were a weak logistic management information that does not capture crucial data to inform budgeting and procurement. A strong logistic management information system provides data on the availability and use of health commodities that are needed to conduct accurate quantification, procurement planning, inform budgeting, resource mobilization, strengthen overall financial management. However, most of the countries that we looked at lacked the adequate LMIS data, particularly for MNCH Commodities, and more so at the subnational level. And so MNCH commodity data is really monitored, which leads to inefficiencies in the system. And so these data are being used for quantification and later procurement, which is not evidence-based. The second bottleneck that we were able to see was a limited capacity, particularly at the decentralized level, to forecast these commodities. These countries often have limited capacity to accurately forecast, especially the MNCH Commodities, in which case the procurement and the quantification is based on previous year needs, even though this information could be out of date. At the subnational level, for example, in Kenya and Bangladesh, each county and district calculates its forecast differently based on past consumption, which is more distribution than consumption. And these estimates, which are based on out-of-date historic information, feeds into the national quantification, which further compounds the inadequacies in the peripheral forecast. Most countries are not using any standard guideline or procedures or tools which could be tailored for quantifying the health commodities. Although under the UN Commission for Life-Saving Commodities, generic guidance documents have been developed, but we found that many countries are not yet using those guidelines, especially the one which was developed by SIAPS along with JSI. Some corrective actions have been taken. For example, in Kenya, they have a budget for procurement of commodities, and most of the times they overspent it. So a system exists that 9 months into the fiscal year, the county reviews current expenditure and can reallocate funds among departments or budget line items based on under or over expenditures. And so it was realized about 50% over expenditure had to be compensated in one fiscal year in Kenya to compensate for the over expense for procurement of commodities. Another example that we observed in Uganda was that these required funding for essential medicines and health facility is not based on the needs of the hospital. So what happens is the national medical store budgets are just made based on a type of health facility. And in the past 3 years, we realized there has not been an increase in the budget of the National Medical Store for procurement of commodities. Although National Medical Store had conducted essential medicine need assessment at the health facility level, however, this data was not used when funding allocation was made for each of these health facilities. The total budget allocated to health facilities is just not based on quantification, but on the budget ceiling for each level that the Ministry of Finance, Planning and Economic Development sets. The National Medical Store would divide the total amount allocated per level by the total number of health facility at that level and simply send kits which are procured for a level of health facility to them. This may lead to either overstocks or understocks, since they do not take into account the catchment area for that typical health facility. And it was observed overall there was a gap of 57% in the need versus what was being allocated for health facilities. The second bottleneck was these dispersed funds do not always match the allocated funds or budget. The reason was identified as lack of staff training who have the capacity to do this reporting and reimbursement. And so what we observed, for example, in Nepal was that there's a turnover of staff who's responsible for reporting of expenses. New staff coming in necessarily do not receive this training, and so they end up submitting reports which may have inconsistencies or which may have incorrect information or lack some of the important information that the Auditor General's office may need to clear their expenses. And this at the end then ends up with the disbursement being lower than what was already allocated. A corrective action taken both in Nepal and Bangladesh is that they have hired consultants who are now training their staff on financial management. Also, for example, in Nepal, a stakeholders meeting is scheduled every quarter, which looks at all the expenses in addition to the other issues for the health programs, and then try and resolve these by ensuring that whatever bottlenecks were identified are addressed by individual departments within the ministry. An example from Nepal, where the fund allocation, whatever was allocated, did not end up being received. For example, just for family planning MNCH, we realized 38% of the total funding was what was dispersed, and 39% from Government of Nepal, 38% from the donors, and this resulted in a lower disbursement, which at the end affected the activities. We did an analysis of the Department of Health Services annual reports to come up with this graphic representation. And so what we saw was there was a range from 24 to 51% for government funds and 2 to 59% for donor funds, depending on the health program. In just 2014-15, only 17% of the total allocated budget for the Integrated Management of Childhood Illnesses program was actually dispersed. 51% of the government allocation was released and only 2% of the donor commitment was met. The third bottleneck identified was a delay in disbursement, which slows the commodity procurement and distribution to some extent. So there's delay disbursement from the national level to lower facilities, either county governments or entities within Ministry of Health who are responsible for making these payments, result in longer procurement and lead time. An example from Nepal, where the average procurement lead time is 9 months. So this delays in disbursement could be partly due to the challenges associated with expenditure tracking and clearing of expenses that delay the release of funds during the first quarter, and so this continues for the following quarters. There are signatory authorities which are to be transferred starting from Ministry of Finance all the way to the divisions within Ministry of Health, and so every delay delays the disbursement process that has to start. And it was found that on an average, there is a 3-month delay between the time the funds are approved to the time the divisions within Ministry of Health and Department of Health Services receive the actual money so they can start expending it. Also, there are complex processes. We were told that there are different reporting formats for donors as well as for government. And so many times what happens is they have to put together an expense report which has same expenses but is on a different format, and they mix the two formats, which leads to some cost becoming questionable and they're not cleared by the Auditor General's office. Hence, the disbursement is stopped till those questionable costs are resolved. This is a typical example which was observed in Nepal. So due to the challenges in tracking expenditure and clearing expenses through the Nepal's Auditor General's office, the quarterly disbursement are either delayed or not fully received by the Ministry of Health. This delay plus the slow release of funds from donor causes funding gap, which may interrupt field level activities. Their total funding is divided into 4 quarters. And so in the first quarter, each of those divisions receive 100% of what was approved. However, any questionable cost and any unspent fund is deducted from the second quarter funding, and so it is lower than what was allocated for that quarter. This further complicates in the third and the fourth quarter, and so at the end, the individual ministry may not end up receiving whatever was allocated. The total spent and received amount sets the limit for the following year budget planning process. And so many times Ministry of Health has to put in an explanation as to why they are requesting higher funding than what they were able to spend in the previous quarter. The last bottleneck that we identified, which seems most important, is there is either no or inactive maternal newborn child health commodity security working group. A commodity security working group is essential to ensure the right amount of quantities are being procured and that there's somebody advocating with public sector, with donors, implementing partners to ensure if whatever is forecasted has also a budget, and that these quantities will be available to be used by the countries. MNCH Commodities have recently become a focus for both local and international scrutiny under the UN Commission on Life-Saving Commodity Work. Unlike family planning commodities, which is usually benefited by a commodity security working group, MNCH commodity security working groups, either they operate within the reproductive health supplies, within the reproductive health commodity security working group, or there are people who may be ensuring that these commodities are available, but they do not meet regularly and in a very formalized manner. A critical role for MNCH Commodity Security Working Group is to ensure that there is adequate financial resources allocated for MNCH commodities to be procured. And so it is very essential that in addition how the reproductive health commodity security working groups exist in country, a similar working group for MNCH commodities should exist, which should be able to discuss, do a longer term forecasting 4 to 5 years, ensure each of the donor, local government, or the implementing partner, whoever is responsible for bringing in the funds, they bring those funds in the country and in a timely manner, and that there is coordination within the different groups. Some countries, for example, in Kenya, the MNCH Commodity Security Working Group, it does exist, but it's very new and not fully established. Its objective to advocate for additional resources at the national level and to strengthen the capacity of the county health departments to budget and procure MNCH commodities is yet to be strengthened. Similarly, in Bangladesh, we found that there is MNCH Commodity Security Group, but again, its capacity and the extent of its implementation is limited. I'll hand over to Jane, who will then brief us on how this mapping and the bottlenecks that we found are useful for future work. Jane, over to you.
Thank you. Could you just go back to the previous slide, please? So I think Maheen has outlined the 5 key bottlenecks that we found. Could you just go back to the other slide, please, Maheen? Thank you. So the 5 main bottlenecks that were identified were that funds were not allocated based on evidence and the issue of prioritization of MNCH commodities. The issue of the fact that the funds that were dispersed do not always match the allocated funds, and there were inefficiencies due to lack of trained staff, record keeping, and so on. She noted that there were delays in disbursement, which obviously has an impact on procurement. There were complex processes for budgeting and reporting, which delayed auditing and so the ongoing disbursement. And then finally, the issue of the absence or weak commodity working groups focusing on MNCH. And I think, you know, what has been interesting, before I go into how this is useful, what has been interesting about this work is that it is really an area that we as program people are not particularly familiar with. And we had an opportunity, Maheen and I, a month or so ago to present some of these findings to health finance people. And they were like, yeah, so we know all this, what's new? And it really kind of came home to us that, you know, that the issue is that often this kind of falls between the health finance, health economist people and health program people. And this whole area comes under an area that's called public financial management, which is often a sort of more governance issue to ensure that these procedures that enable the flow of commodities, flow of funds, rather, through the system is efficient. And so this public financial management that all of this is linked to is crucial, I think, for ensuring that there are available resources for the procurement of MNCH commodities. And I think one of the important things about this mapping is that it can be used as a way to bring people together who don't often sit at the same table and who maybe speak different languages. That, you know, those who are on the program side, those who are on the finance side, and then those that are sort of assuring those financial procedures to make the flow of funds. And so looking at how they could improve on the inefficiencies and make them more efficient through standard procedures and so on. So that was just a kind of a thought that I wanted to share before we go on to the end slide, the last slide, which is how this mapping can be useful. And so in addition to what I've just said, if you could move on to the last slide now, please, Maheen. What we've seen is that an understanding of these financial flows for MNCH Commodities is critical. Firstly, to allow us to implement strategies to resolve what are often very complex financial processes and the other bottlenecks that we came across to facilitate adequate and timely procurement of MNCH commodities. And obviously through that, procurement being adequate and timely, then we increase the likelihood of having available MNCH commodities. And here we're looking at the scenario where there isn't extra funding that can be allocated. So we're using to the best that we can, making efficient use of the funding that's already allocated. Secondly, I think that this is useful for countries to recognize that there may be a need to mobilize additional resources, both domestic and international, but also to increase on efficiencies. So that's number two, to really kind of look at how those complex processes can be made more efficient. And thirdly, to help orient the donor community to maybe make smarter investments, not just thinking about allocating funding for the procurement of commodities, but seeing how there are delays and bottlenecks within the flow of those funds through to the point of procurement. Maybe donor communities should be looking at focusing more on the commodity working groups, looking at investing in the assessment and facilitating this whole public financial management, looking at developing procedures to streamline some of these procedures, rather than just looking at funding for procurement of commodities as such. And then lastly, to help countries look at prioritizing where their budget may be insufficient. And so I think Maheen alluded to some examples where MCH programs and so MCH commodities are priority, but how can we ensure that they are prioritized in the procurement and the flow of funds over paracetamol, for example, and other medicines that are in the essential medicines package? And then lastly, to think about the point that I'd raised earlier on is how we can bring these people together from different disciplines, from different areas within the government to ensure that the flow of funding can be facilitated. So I think I'm going to stop there. I do see on my screen, Milka, that there are some unanswered questions, but I don't think as a presenter I can actually see what the questions are. So I think we're at your mercy to hand the questions over to us. Thank you very much for your attention, and over to you, Milka.
Thank you, Jane and Maheen, for this very, very didactic presentation. Extremely easy to follow the concepts and the flow of information. We have several questions. I have one from Kabir Ahmed. Any attempt made to explore the proportion of procurement of MNCH commodities by the donors, partners, in addition to the government, to the ministries of health procurements for the public sector?
So it's just that in most of the countries that we visited and did the assessment in, there's a system for a pooled funding, and we were told once the funds are put together, for example, both in Nepal and I guess also in Bangladesh, once it's part of the pooled funding, then there is no bifurcation as to how much was coming from, what is the percentage coming from the public sector and the donor community. However, the slide that I showed about from Nepal, where the FPM and MNCH commodities were being procured and then the fundings that were decreased, we see that there is at least about 60% of it may come from the 60 to 70% from government budgets, especially in Bangladesh. about 80% comes or 85% comes from the government funding, and very little, especially just for MNCH, and I'm not talking about in general the commodities, but for the MNCH commodities, we were told most of the funding comes from the government of Bangladesh revenue funds and very little from the donors. And the reason for procurement, they usually follow the government of Bangladesh's guideline for procurement. However, they also, for the funds that are used through World Bank and other, they do follow the donor guidelines. But clearly, each country had a different percentage allocation between what is given by the government revenue funds versus what the donors would bring in. For example, in Uganda, MNCH is not a priority, so most of the donor funds are put towards either HIV/AIDS, and so we assume for MNCH commodities, it's most of the government sector revenue funds which is used.
Thank you so much. We have another question from David Eckhout. In theory, if a centralized and a decentralized system would both operate as good as possible, would one be better or more efficient than the other? In short, is there a preference taking ineffective applications of the systems out of the equation?
So if you ask me, I mentioned even during the presentation, a combination of both was something that we found most efficient. In theory, if the decentralized system follows all SOPs, then that would be a more efficient system, because then instead of the whole information flowing to the national level where the decisions are made, these decisions could be made at the subnational level where maybe information on what the health facility requirements can be made. However, for procurement to be more cost effective, a national level procurement usually helps than something happening at the subnational level, because then there will be lesser quantities that are to be procured. Hence, a combination of both is something I still maintain is the best, but that's my judgment. Each country was following their own systems. But as we see, for example, in Nepal, they're going through a process of decentralization, which means even they realized a decentralized system may work better than a centralized system. Indicates that if, again, all these standard operating procedures are followed, a decentralized system may work better, because then the decisions can be made really on ground preferences and what is happening on ground at maybe health facility and district level.
Yeah. Let me just add to that, Maheen. I think that's a good answer. But I think also just to clarify that we presented the difference between decentralized and centralized as a way of framing the context within which the study was conducted in these different countries. But certainly the aim of the mapping was not to compare one with the other. And I don't think that we necessarily looked at the necessary measures to be able to compare and come out with a decision at the end as to which is better. But I think, Maheen touched on two important points. The economies of scale of conducting procurement at large scale at national level is something that's very beneficial about a national centralized system. And also the mechanisms in place to assure the quality of commodities. But that said, in a decentralized system, if there are the efficient mechanisms in place to assure quality at that level, then that shouldn't be a bottleneck. And you did say in your question, if they worked correctly. So I guess, yeah, a combination of the two is probably where we would go. But like I say, that doesn't necessarily come out of the findings of this study.
We have a question from Betty Hanoun. Are patients charged for MNCH commodities in any of the countries? If yes, how are patient fees distributed?
Okay, so we were told most of the MNCH programs are free of cost. And so in theory, none of the patient is supposed to bring in or purchase commodities from open market or pay for services. It should be made available through the hospital, through the public sector. However, in case there is a shortage of commodities, we were again told we did not go all the way to the health facility level to interview. However, in our discussions, it came up that if a certain product is not available with the hospital, then the patient has to go and purchase it from outside. In Nepal, there is a program which is Amma Suraksha program, where actually the government reimburses for any health facility-based births, just to promote people giving birth at health facility, where the patients are being paid for being delivered at a health facility, health worker for convincing a pregnant woman to deliver at health facility, and for health facility to ensure the commodities are available. However, it's at the discretion of the medical superintendent of the hospital how he wants to use this reimbursed fund. It could be used for procurement of commodities, and it could be used for anything which is bringing in diagnostics, for any infrastructure. So in theory, patients shouldn't be paying for these commodities or purchasing it from outside market, but there are examples when the commodity is not available, where the patients did end up purchasing it from open market, to an example where the health facility is actually reimbursed for facility-based birth, but it's at the discretion. So there is no clear-cut guideline how this funding should be used. I hope that answers.
We have a question from Shafia Rashid. Following the completion of the analysis of bottlenecks and proposed actions to address them, will they be shared with national stakeholders so that they are aware and can take steps to address them?
Yes, all these reports have been shared with Ministry of Health, all the stakeholders, also with donor communities. Each country is at a different level of sharing this information and at a stakeholder, organizing a stakeholder meeting, or just sharing these with individual stakeholders, and Jane can further expand on it.
Yeah, I mean, I think that's where we're at now. The reports have been shared with each of the countries, as Maheen said. I think a particular case is Nepal, where currently USAID does not want the information, the detailed country report shared widely at this stage, because there is a lot of political transition going on, developing the decentralized structure. And so USAID has requested that this be on hold until after that has been determined, and at some stage in the new year, then these findings, although at that stage they will be dated because they relate to the older system, but they can be useful to improve how the new system is set up. So that's the exception for Nepal. For the other countries, both the USAID mission and Ministry of Health counterparts have the reports. They have had discussions with ourselves and with our local teams in country on the findings. And in each of those three countries, they are organizing technical meetings, either as part of other ongoing activities of other programs or as a sort of standalone meeting to discuss the findings of these. So yes, that definitely is the next stage. Unfortunately, the SIAPS program is coming to an end, and so there's a limitation in how we can support those next stages, but we feel that we have set the stage for that to continue in each of the countries through other mechanisms and through the input from the ministry and from USAID.
We have several questions, so I would suggest that the answers are a little bit shorter. We have another question from Kabir. In at least 2 of the 4 study countries, as I know, there are functioning commodity security committees. Are these commodity security committees involved in the government budgeting process?
So these commodity security working groups, for example, both in, as I said, in Kenya it exists, Bangladesh, Nepal, but in budgeting process, I would say no, but they are part of once the procurements and quantifications are done. So in a way, yes, they do sit when the national level forecasting workshops are conducted, but not necessarily being part of the budget discussion, which mainly happens between public sector stakeholders and maybe donors.
Okay. Another question from Kabir. Is there any budget line specifying for MNCH Commodities in any of these 4 countries? If not, from which broader pot of the budget line are the MNCH Commodities procured?
There are line items for individual commodities as well, and we witnessed it in both Nepal and Bangladesh. They did have a line item, for example, how much oxytocin was supposed to be procured and how much actually ended up being procured in 2 different documents.
Megan Rauscher says, a great presentation. Thanks so much for sharing. Within your analysis, were you able to see any differences between funding streams and how these flow through the system? For example, donor funding versus domestic revenue, brackets, revolving drug funds, insurance schemes, etc.
Jane, you want to answer? You want me to answer?
Go ahead, Maheen.
Okay, so as I mentioned, some countries have a pooled funding mechanism where everything is put together and expenses are made from that pooled funding, in which case the stream follows the same procedures. However, there are countries, for example, in Uganda, where government revenue funds are mainly used for procurement and some of the donor funding is also used, in which case there are 2 different streams that follow. And depending on what the donor has agreed, it will still have to, maybe they may just bring in-kind donation in form of commodities versus them giving the money to Ministry of Finance or Ministry of Health for them to procure. So really it depends how the system is in the country.
And we have 2 questions from Kimberly Whipke. Hi, where do you think that advocates can have the most impact with influencing financial flows for MNCH medicines? And question number 2, is this mapping available in a report?
I'll take the second answer, second question, which is yes, reports are available, and once the presentation will be made available through the Maternal Health Supplies Caucus, we will also add the links to individual reports, except Nepal, as mentioned by Jane, since for now the country is undergoing devolution, and so USAID doesn't comfortable us sharing the findings at this stage. For the first question, Jane, you may go ahead because that's the last slide and you may elaborate on it.
Yes, I mean, definitely there is a role for advocates to look into what can be done to improve the way that funding flows through the system. And I think clearly in each country, as we've seen, there are differences. We've kind of summed together some of the key bottlenecks that we found that are common across these 4 countries, but that doesn't mean that each of those bottlenecks will necessarily apply in every country. So I think that in each country, you would need to take a look at those bottlenecks that we identified and see if they apply and see if there are others. I think, straight up, I would suggest that the commodity working groups and the roles of the commodity working groups would be an important area to work on. And, Kabir mentioned that there are functioning commodity working groups in a number of countries, and yes, there are. But I think for family planning, reproductive health, they're much more advanced and much more active than they are necessarily in the field of maternal, newborn, and child health. And so I think either combining those pieces into one commodity working group for RMNCH or strengthening the role of an MNCH commodity working group would be a good place to start, and strengthening their role in advocating for funding allocation and it not just being limited to looking at the security of those commodities. But I think certainly, as I mentioned before, looking at the issues of public financial management and getting those different disciplines, different people around the table would be something to look at. I hear Milka's coming on the line, so I think it's time to wrap up.
So thank you so much. We have hit the hour now, so we will close this webinar in a few seconds. There are 2 or 3 more questions from Kabir. So I strongly recommend, Kabir, if you would get in touch with Maheen, that would be best. If you need her email, let me know, and I can introduce you by email. So with that, I would like to open the microphone to Jane and Maheen to say goodbye and to close the webinar. And I thank you so much for the effort and for the hard work of doing this presentation and these fabulous results. This is our last webinar for the Maternal Health Supplies Caucus of this year, and I think we're closing with a golden note. So thank you, Jane and Maheen, and please do say the final words.
Thank you very much, Milka. I think we've hit the time, so I don't want to extend it further. Thank you very much for your attention. This is interesting work. It will be available. The links will be shared, as Milka said. There will be a link on the SIAPS website, which we can also share, that has the documents. And thank you very much for your time.
So thank you. And another just a note that if anybody has more questions, please feel free to send them to us through Milka, and we'll be happy to have individual discussion if need be.
So goodbye and have a great weekend. Bye-bye.
Bye.